guys, welcome to my vlog. So today let me fix my camera first. Okay. Okay. Hello, I'm Hanley Ong and I will be performing and discussing specific ophthalmologic topics. So I'll be starting off with the basic ophthalmologic examination, which is a 5-point exam consisting of your visual acuity, adnexa, tonometry, extraocular movements, and fundus examination. So in testing your distance visual acuity, we use the Snellen chart, which is about 20 feet away from the patient. Since this is a home eye test, at least 10 feet is enough. So I have here a printed modified Snellen or adult's eye chart from the American Association of Ophthalmology. So make sure that the biggest letters are under 1 inch tall. So assuming that the patient is about 10 feet away from the chart and at eye level with the chart, so you ask the patient first if she's wearing any glasses or corrective lenses, and then we usually do this one eye at a time. By convention, we start with the right eye. So ask the patient to cover one eye by cupping her palm on her eye without putting pressure. So ma'am, gagamit o ganchubos? Wala. Ma'am, pwede ni mo tabunan imong left na mata. Iyan na ma'am din ayaw kuan doon. So we start this by asking the patient to use the biggest letter and then move on to the next line. Ma'am, basa lang sa akong i-point na letters. H, O, R, C, H, N, O, S, Z, V, S, D, R, Z, C, O, H, R, V, C, S. So since the patient was able to read more than half of that line, so the patient's visual acuity is 20/20. So you do the same for the other eye. So visual acuity is 20/20 for both eyes. In reporting, the numerator is the distance at which the patient is able to read the letters on the Snellen chart, whereas the denominator is the distance at which a normal person is able to read the letters on the Snellen chart. So a normal visual acuity is 20/20. So if the patient is unable to read the letters at 3 feet away from the Snellen chart, we do the counting fingers. So we start off at 3 feet and then 2 feet, 1 foot, and 6 inches. If the patient is still unable to count the fingers at 6 inches away, we do the hand movement. So you ask the patient to close his or her eyes and move your hands and make sure there is no sound or error. So if the hand movement is perceived, we do the light perception by shining a light on all 4 quadrants and asking the patient to point to the source of the light. In near visual acuity, this is usually used for patients over 35 years old or presbyopic patients and those with blurring of vision at near. So if the patient has corrective lenses, let them use it during the examination. So we usually use the Yeager chart at 14 inches or 35 cm away. For adnexa or gross examination, we shall inspect and palpate the periorbital area and the lids. So note for any foreign bodies, hemorrhages, exudates, or redness. So first, I'm going to check the orbital rim for any orbital fractures or septal deformities, the cheeks for hypoesthesias, the conjunctiva for inflammation, infection, or any exudates or redness you may find. The semicircles on the chart represent inverted eyelid or conjunctiva. Indicate if there is foreign body, papillae, also if there is any crepitus, hypoesthesia, or step-down deformities. So you may also draw your hemorrhages and also your periorbital edema. So if findings are normal, put a slash on the semicircle. Now I'm going to check the lids and the sclera. So the normal upper lid should cover 1 to 2 millimeters of your upper limbus, while your lower lid should rest on the lower lumbus. Next, I'm going to check the pupil for direct and consensual light reflex. So using your pen light, shine the light for this is for your direct light reflex. So you shine the light on one eye. Then as you shine the light on one eye, you check if there is any constriction of the pupil. So note if it's brisk, if it's slow or non-reactive. So you do the same to the other eye. So for this patient, the direct is brisk constriction. For your consensual light reflex, you shine a light on one eye, and as you shine the light on one eye, you check for any constriction or dilation on the other eye. So note if it's brisk, slow, and non-reactive, if it's constriction or dilation, and then you do the same thing for the other eye. For this patient, direct and consensual for both eyes are positive. So next we do the relative afferent pupillary defect or the Marcus gun. So this is done in a swinging light motion or swinging light test. So again, we swing the light on one eye. We shine the light on one eye, and then as you swing the light to the other eye, notice if there is changes in constriction or dilation. So as what I've seen in the patient, there is constriction, meaning that she doesn't have any relative afferent pupillary defect. So in the case of an affected eye, when you swing light on the affected eye, check if there is dilation or constriction. If ever there is dilation on both eyes, it means that there is less sensory input on the affected eye. So your RAPD is actually relative to a normal eye. So there is no bilateral relative afferent papillary defect since you won't be able to test since both have no sensory input. So question is if you can check RAPD if the patient has no pupil or non-reactive. Yes, you can, like in the case of total hyphema. So you swing the light to the eye with no pupil. And you also check the other eye if there is any dilation or constriction. If the eye or the pupil on the other eye constricts, there is no RAPD reported as negative reverse RAPD of the normal eye. But if it dilates, it means that there is positive RAPD. So we report this as positive reverse RAPD of normal eye. And the conjunctiva for infection. Next is tonometry. This is used to estimate the intraocular pressure by using our index finger by doing a digital palpation. So in doing this, ask the patient to look down. Ma'am, pwede mo lang to ka sa ubos. So do not ask the patient to close her eyes since this will elicit the Bell's phenomenon or the eye lifting due to the closure of the lids or eye going up. So you palpate the eyes. So the normal findings for tonometry is 10 to 21 millimeters mercury, but since we're just estimating it with palpation, we can compare this to the specific structures. So patient's IOP is soft. So soft is the tip of the nose, which is the normal. Hypotonic is the lower lips, and firm is your forehead. For your extraocular movement, so we do this by asking the patient to follow the index finger in the 6 cardinal directions of gaze. So, ma'am, sundar ang akong kamot. Kani, ay regigimok yung ulo. So, you usually draw a big H in the air. So, we start with the patient's extreme right, right upward, right downward. Without passing through the middle, we go to the extreme left, left upward, and left downward. So note if there's any nystagmus or sluggish of movement, ask the patient for any pain on movement, and if the patient has diplopia. So ma'am, na nabating sakit pag lantaw? Ni dubli ang inyong kanan or wala. So the patient's EOM is full and equal on both eyes. Test versions first on both eyes at the same time. If results are abnormal, do the duction one eye at a time. So in reporting, arrowheads represent the right eye and circles for the left eye. In fundus examination, We check for the blood vessels, the optic nerve, the macula, and the retinal background. So first things first, we need the ophthalmoscope for us to check the fundus. So here you can see this is the patient side of the ophthalmoscope. We have here the aperture, or also known as your viewing window, and this is your filter switch. So if you move here, this is your examiner side. So in the examiner side, we can see the aperture or the viewing window, the diopter display, and at the side, we have your diopter dial. So before you start examining, make sure that your ophthalmoscope is working and check if there is good light source. So you start with the largest diameter. You can adjust that using the filter switch and adjust your diopter to 0 is here. So a dimly light room is the best setting to do your fundus examination, for this will not elicit the constriction of the pupils. So assuming that this is a good setting for this examination, so you use your right hand and your right eye when examining the patient's right eye, and you do the same thing for the left eye. So first thing is you start by staying 1 foot away from the patient, and then check for any red-orange reflex. So once you locate the red-orange reflex, you slowly come closer to the patient. So in a 15, temporarily in a 15 degrees from the patient's gaze. So in this setting, you ask the patient to look away. So ma'am, pwede ka muna to dito sa wall. So as you locate, you may adjust the diopter. And then once you find the retinal vessels, you may go nasally to find the optic disc. In reporting your fundus examination, the red-orange reflex is reported as positive. Normal ROR is evenly colored with no interruptions of shadows. So you also check for opacities of your lens and cornea. So the media should be clear. The optic disc is normally slightly oval vertically and pink in color with no hemorrhages. The cup is usually a central depression of the surface. The margins should be clear and the disc border should be distinct. So next we have your cup disc ratio, normally 0.3 to 0.4, or that is less than 0.5, or you can have, as long as it's not more than 0.2 difference in both eyes. So for the retinal circulation, the artery to venous ratio is 2:3. So you check the second branching of the vessels. So for the retinal background, normally it should be uniform red-orange in color. So also check for hemorrhages, exudates, and any abnormal lesions in the background. So we also have your foveal reflex. So this is actually a bright pinpoint of light moving in coordination with the movement of your ophthalmoscope. So we report this as good. So special eye procedures include your Hirschberg and Bruckner's test, collectively known as your corneal light reflex test. Hirschberg's test is used to determine the approximate positions of the visual axis, or simply to check for any misalignment. As we use a pen light, so first thing, you make sure that the patient and the light source is about 50 to 100 cm away. So assuming that the distance between the pen light and the patient now is 50 to 100 cm, you ask the patient to focus your gaze on the light source. Ma'am, lanto ra ani suga ha? Dili ra tuto. So make sure that the light is distributed equally and at the patient's midline. So you observe the reflection of the eye, of the cornea, and observe the bright white light if it's central to the pupil of each eye. So the patient's Hirschberg test is symmetric. Normal findings of your Hirschberg's test is symmetric or orthophoric, meaning that the reflex is seen at the center of the pupil. So abnormal findings include your esotropia, wherein the reflex is seen more temporal, exotropia more nasal, hypotropia more superior, and hypertropia more inferior. Bruckner's test, this is used to determine or assess the binocular fixation by comparing the red reflex of both eyes. So this is also used as screening for strabismus or media opacities. We'll be using the ophthalmoscope. The distance of the patient and the ophthalmoscope should be about 80 to 100 cm away. So assuming again that this is a 80 to 100 cm distance, so let the patient look at the light source and you observe for any red reflex. So the patient's Bruckner's test is OD equals OS. In Bruckner's test, a fixating eye is signified by a dark red reflex, whereas in abnormal, deviating, or non-fixating eye has a reflex that is whiter, brighter, and lighter. These two tests, your Hirschberg and Bruckner's test, are actually used to assess for amblyopia, also known as your lazy eye, wherein the vision does not properly develop during childhood on one or both eyes. So causes of amblyopia include your strabismus, refractive error, cloudiness of the eyes, and droopy eyelids. So management of your amblyopia is to let the child use the weaker eye, usually by applying an eye patch. Lastly, I'll be discussing the two true ophthalmologic emergencies and how to approach them as a medical student in the emergency room. So the true ophthalmologic emergencies include your bilateral optic disc swelling and your chemical injuries. Starting off with your bilateral optic disc swelling, this is a characteristic feature of an increased intracranial pressure and malignant hypertension. This may be caused by your acute angle closure glaucoma and your central retinal artery occlusion. So your glaucoma is a chronic acquired optic neuropathy manifested as an optic disc swelling or your visual field loss with severe pain. So basically, it is the damage of the optic nerve due to the accumulation of fluid in front of the eye that increases the pressure that leads to the damage. So the three findings of a glaucomatous optic nerve include your loss of disc substance, your enlargement of cup disc or increased cup disc ratio, and pallor in the cupping of the disc. So initial treatment of your glaucoma include putting the patient in supine position so as to push the lens posteriorly by gravity. So next, you may give the patient acetazolamide, IV or oral, depending on the IOP. The second cause of your bilateral optic disc swelling is your central retinal artery occlusion, which is a profound and sudden painless loss of vision. So treatment of your central retinal artery occlusion includes putting the patient in supine position. We may also do an ocular massage. We may also do an anterior chamber paracentesis or let the patient breathe a mixture of oxygen and carbon dioxide. So in patients that come to the ER with bilateral optic disc swelling, papilledema, which is the optic disc swelling due to increased intracranial pressure, must be identified, particularly in patients with neurologic symptoms, specifically your headache. So this is usually discovered incidentally during a routine optometric examination. Nevertheless, urgent imaging should be done to exclude any intracranial mass lesions. So blood pressure should be checked on every patient with optic disc swelling, even in children. Precipitous reduction of pressure is avoided to reduce the risk of optic nerve infarction. Last ophthalmologic emergency is your chemical injuries, which may be due to a splash or spray of industrial or agricultural solutions, cleaning solutions, automotive fluids, or cements to the eyes. In children, this is usually a cleaning solution or detergent. Most important first step in a chemical injury is to have copious irrigation with normal saline solution or Ringer's lactate for 15 to 30 minutes or up until the pH is neutralized. So the next important step is to know the nature of the chemical, if it's alkali or acidic, since this will differ in the management, for these two agents have different penetrating capabilities to the tissues. So this would be the end of my discussion, and thank you for listening.